The appearance of protein remains the primary diagnostic criteria. It is an objective marker and reflects system-wide endothelial leak that characterize the preeclampsia syndrome. The pathogenesis is multifactorial and with known influence by placental, vascular, renal, and immunological dysfunction. And this is a case of severe by onset preeclampsia complicated by antepartum intracerebral hemorrhage, presenting as a severe new onset headache with vomiting, mimicking impending eclampsia clinically or existing alongside with another grave complication. So everybody knows that the incidence of subarachnoid hemorrhage is around 3 to 9 per 1 lakh pregnancies, and the remaining main cause is ruptured saccular or berry aneurysm, and the remaining causes are arteriovenous malformation, coagulopathy, then angiopathy, venous thrombosis, infection, drug abuse, tumor, and trauma. So my case was 35-year-old female, gravida 2, para 1, living 1 at 32 weeks, 5 days of gestation, DCDA twins, IVF pregnancy, known case of pre-gestational diabetes on insulin, was referred from local hospital as an impending eclampsia. She had received capnicardia and loading dose of magnesium sulfate. She came to emergency and her history was suggestive of new onset hypertension with sudden onset of severe headache associated with vomiting since few hours. So on general examination, pulse rate was 102, BP 180 by 110, SpO2 98%, and respiratory rate was 18, GCS was 15. Per abdominal examination revealed overdistended uterus with multiple fetal parts, and NST revealed reassuring fetal heart rate status in both fetuses. No other clinically significant finding. 0. Bishop score was normal, US 0. USG revealed good biophysical profile in both fetuses. Lab investigation on admission, hematocrit was normal. Coagulation profile within normal limit, no proteinuria, ketonuria 3+, liver and renal function within normal limit. So our BP was controlled with parenteral labetalol and maintained with oral labetalol. Magnesium sulfate IV maintained, dose continued. Patient general condition was improved. We actually give multidisciplinary approach, and we advised her to take MRI, but patient bystander refused that. So we decided to do cesarean delivery planned after 48 hours of antenatal corticosteroid, keeping level 3 NICU ready. On OT table, CS while was found uniformly blood stained while administrating the regional analgesia, anesthesia. Traumatic tap was excluded. Bloody CSF and CSF xanthochromia led to high index of suspicious of subarachnoid hemorrhage. So post-operatively, patient continued to have headache despite of BP being maintained below 140 by 90. So we did MRI. So it was suggestive of subarachnoid hemorrhage. So we have transferred patient to Kottayam Medical College for under neurosurgery. They have done CT and it was suggestive of subarachnoid hemorrhage in circle of Willis. So she was managed symptomatically, and she's fine now. She's taking only one antihypertensive drug now. So discussion risk factor for preeclampsia in this gravida included advanced maternal age, multifetal gestation, pre-gestational more than these, ART, and last childbirth like more than 12 years. So 35-year-old gravida at 32 weeks with twin gestation with new onset